Many thanks to the Multiple Sclerosis Association of America, MSAA, for making this show possible. MSAA's mission is to enrich the quality of life for everyone affected by MS.
Hello and welcome. We're going to be talking tonight about multiple sclerosis. We did a show on this topic about a year and a half ago, and we are revisiting it because there have been some exciting new developments in the world of treatment and some new information about causative connections. My guest is back. Dr. Gary Birnbaum is with me again. Dr. Birnbaum is the director of the Multiple Sclerosis Treatment and Research Center with the Minneapolis Clinic of Neurology. It's great to have you back, and I have all kinds of questions for you again.
Good. Thank you for inviting me.
You're very welcome. I'm sure some of the viewers that are with us tonight were not with us when we did the first interview, so I'll ask some questions that
Sure.
are repeat questions, but I always find that when I hear something a second time, I often hear it differently because I've learned some new things in the meantime, so to speak. So first, let's just have you define, Dr. Birnbaum, multiple sclerosis. What do you tell people who know nothing about it?
Okay, well, what I say is that MS is the disease of the central nervous system of the brain and spinal cord. It doesn't usually affect other organs at all. It's a chronic disease, it's a long-term illness, and there's a lot of inflammation in the central nervous system in people who have MS. It has a very variable course. People initially, when they hear the term MS, they think of wheelchair, and of course that can happen, unfortunately, but it doesn't have to. So it's a long-term inflammatory disease that affects mainly the brain and the spinal cord.
We're learning more about the brain in the last decade, but I think for most of us, the brain is such a mystery. Is there a certain part of the brain that's more connected to MS?
Well, it actually varies among individuals. There are some individuals who only have involvement of their spinal cord, and other individuals who have major involvement of their brain without too much involvement of the spinal cord. Of course, the reasons for that are entirely unknown, but as you can imagine, the course of those individuals is going to be very, very different.
Is it less worrisome if you have one or the other?
Well, it depends upon what you mean by worrisome. I think having MS is always a worrisome situation. People who have spinal cord involvement tend to have more abnormalities of movement, abnormalities of balance, of weakness. People who have abnormalities of their brains may have more abnormalities of their eyes, of their vision, of their thinking.
That makes sense. So different things affected by the different
Yes.
source. MS is on the increase, I've learned from you and from my reading. What kind of change have we seen in the last 50 years, roughly?
Well, this is really a true mystery in terms of the disease. People have looked at the incidence of MS for almost 100 years now, and it's been much better documented, of course. But what's happened in the past 100 years is there's been a very dramatic increase in the incidence of MS among women. It's predominantly a disease of women, but women have been disproportionately affected. So if you look at the incidence of MS in women, it's much higher over the past 100 years than in men. So something in the environment, something has happened in the past 100 years that seems to have affected women more than men.
But as you explained to me earlier, we don't know what that is.
We don't know what it is. Is it the Industrial Revolution? Is it something to do with environment? Something to do with exposure to infectious agents at different ages? We don't know.
And it must tie in somehow to hormones, but women have the same hormones that we had 100 years
Yes,
ago.
yes.
So that's not the variable.
So it's probably some environmental factor. We don't know what it is.
Are there any suppositions that are getting more attention?
Well, people have looked at viruses, as you know, as potential causes or at least inciting agents in MS. We know that there are many factors involved in people developing the disease. There's a genetic susceptibility for the disease. How people respond to various environmental agents is dependent upon their genes. So the same environmental agent in people of different genetic backgrounds may have radically different effects on that individual. Obviously, hormones has something to do with it. Age has something to do with it. There's so many factors that could possibly alter this pattern.
As a physician, I'm guessing it is both exciting and frustrating to be in a field where there are so many unknowns.
Well, it's very exciting. The past 20 years have really been a revolution in terms of our ability to do anything really in terms of altering the course of the disease. It used to be diagnosed in adios, as we talked about, as early as the 1980s and early 1990s. And then suddenly in the past 20 years, we've had this amazing accumulation of potential therapies that really have been effective in altering the course of the disease. Unfortunately, there's no specific therapy that offers us a cure at this point.
But exciting news to think there is all this research being done.
Absolutely.
With good things happening.
Absolutely, yes, yes, that's very true.
That's got to give people who are newly diagnosed hope.
Have much more hope than we had 20, 30 years ago, yes.
That must have been very hard back in 1980 to give someone this diagnosis.
Well, yes, it was hard, but as I mentioned earlier, having MS does not necessarily have to mean a major disability. So even if you made the diagnosis, there was still a large element of hope.
Yes, one would hope. I'm not going to be one that ends up in a wheelchair.
That's correct.
Or has a severe case. And we'll talk more about the different types. But I want to just talk a little bit more about some of the connecting things in terms of geography and gender. The northern tier of the U.S. has more cases than the rest of the country. Does that hold true too in Europe? Dr.
Yes, that holds
Birnbaum?
true in Europe. There's a very high incidence of MS in the Scandinavian countries and Germany. As one approaches the Mediterranean, there's a lot of MS, but it's much, much less. The reasons for that are, of course, uncertain. Part of it has to do with genes. The people in the northern parts of the world have a different genetic background than those in the south. The same is probably true here in America also. So again, it's not any simple connection between the geography and why people get the disease. There's probably multiple factors involved. Vitamin D may be an important factor. Sunlight, we don't know that for sure. But these are all issues that are being looked at very intensively.
I'm just thinking as you talk and wondering if they've done studies with twins where perhaps one twin would live in the northern part of the country and another in the southern, and would they both be as vulnerable to getting MS?
Well, there have been studies of twins reared apart, and the frequency of MS in twins is not 100%, so it's about 25%. So even though you're genetically identical, there's still other environmental factors that play an important role in whether you develop the illness.
Interesting. So you couldn't, I mean, that limits the study quite a bit, doesn't it, or a potential study?
It does. People have looked at this very extensively. They've looked at other factors, environmental factors that might affect gene expression, for example. Haven't found anything yet, but I can tell you the work is very active and is ongoing intensively.
Where are the kind of main hubs in the world in terms of studying MS? I'm guessing right here in Minnesota.
There's a lot going on here. There's a lot going on all over, actually. There's a lot going on in Europe. There's some very excellent centers for MS research, certainly in Europe, in America.
I'm guessing Amsterdam.
Amsterdam has a large center. There's some in England, in the Scandinavian countries. Here in Minnesota, of course, the Mayo Clinic has a large center. And the East Coast, West Coast, San Francisco, there's a lot of interest in MS now.
the numbers of people who get it, you said it really ranges. It might be 1 in 5,000, 1 in 10,000. So it's not a rare disease. It's not a common disease.
No.
But because you said it strikes primarily people in their middle years, that might account for the higher interest proportionately.
Well, it certainly isn't as common as cancer or Alzheimer's or stroke, that's true, but it affects people in their prime, and so has a wide range of effects on families, children, various things like their jobs are obviously going to be affected too if they have a significant form of the disease. So it isn't just you have the disease, the ripple effect is quite enormous.
Right. And the number of years you have the disease.
It's a long-term disease, definitely, yes.
We think of Parkinson's, we think of Michael J. Fox, we think of depression, we think of Mike Wallace, who just died. Is there any well-known person who has MS that speaks out, that helps educate the public?
There have been a bunch of individuals. None of them leap to mind at the moment. There was a Jacqueline Dupre. I don't know if you remember her. She was a famous cellist. Very famous, very talented woman, and she had MS, and she became very badly disabled. There's a variety of people who are in the limelight who've chosen to be advocates for the disease, which I think is very, very important.
That is important. When it has such we entitled this show MS, a syndrome with many faces. There are so many different ways that it progresses, aren't there?
Yes.
Maybe we should talk about those right now. There are 4 main patterns. Is that the right word?
Yeah, I think you can call them patterns. There are 2 that are most common. About 85% of individuals at onset of the disease have what's called the relapsing remitting form of the disease.
85%.
About 85%.
Yeah,
that's
a
the
big
majority
number,
of individuals,
isn't it?
correct.
Yeah.
And by that I mean they have onset of the disease fairly rapidly. They have what are called attacks or exacerbations or relapses within a matter of hours or days or weeks. They'll have a change in their neurologic status. Varying things can happen to them, of course. Any function of the brain can be affected. And it can persist for up to days or weeks or months. There are various degrees of resolution. Some people recover completely, and some people have residual difficulties, and then they may go weeks or years or decades between attacks. About 10 to 15% of people don't have that pattern. They're usually older. They're usually 50-50 men, women. And they have what's called primary progressive MS. They can't tell you when their disease began. It's just very insidious, very gradual difficulty with whatever they have.
Very subtle symptoms.
They don't have attacks and remissions. They just have a gradual progression. About half of people with the relapsing remitting form of the disease go on to have what we call secondary progression. They don't have attacks anymore. They don't have exacerbations. They just very gradually have a decline in their abilities over years and decades.
And so they might even just think the MS, I'm done with the MS and I'm just aging.
That's correct, but you don't have to be very old. What's important, I think, in terms of understanding this is that MS is an evolving disease. That is that the treatment varies with the phase of your disease that you're at.
Say that again, the treatment varies. Oh, so you might be having a very intense treatment
at one part of your disease, and it will be ineffective later on in the disease.
Okay, that I did not know. In terms of the 3rd and the 4th kinds, would you go over those?
The 3rd and the 4th kind, secondary progression would be the 3rd kind. You have relapsing, remitting, and primary. Then half of those go on to secondary progression. And then the 4th kind is very rare, people that have a combination of primary progression and attacks and remissions.
And that's just 5% of
5%,
the
yeah,
group,
that's very
right?
uncommon.
Okay. What would you say would be the most common symptoms for the 1st kind, the most common kind, the remitting, relapsing?
Well, the 2 most common ones probably are alterations in your vision which can be the result of inflammation of the optic nerve.
With blurred vision,
You can have
Gary, or-
blurred vision, you can have a spot in your vision, you don't see as well. It's usually only in one eye. You can have a change in color. Colors look very, very faded. You can have pain in your eye. When you hurt the eye, when you move the eye, it hurts because the optic nerve is inflamed. That's very common. It's called optic neuritis. You can have a change in sensation, a numb face, a numb hand. All of us have numbness. You cross your legs, your feet get numb. This is persistent numbness. It has to last for more than 48 hours. And it has to be compatible with something going on in your central nervous system.
So different from neuropathy?
Yes, you can have numbness with neuropathy, you can have numbness with alterations in your circulation. So you have to be able to dissect out the cause of that particular symptom in that particular individual. Since these are usually younger people, it's unlikely to be the result of having a vascular abnormality like hardening of the arteries. So it becomes a challenge.
So I bet a lot of people that you see initially are referred by an eye doctor.
Yes. You can have many different forms of eye abnormalities. The most common, as I mentioned, is an alteration in vision. You can have double vision. You can have jumping of your eyes. Any function of the central nervous system can be the initial symptom of MS.
Do you find that people are getting to you pretty quickly after they have their symptoms kind of recognized, or do they tend to be, I can imagine they could say, oh, this is odd, this is out of the norm, but it's a passing thing, and blame it on a long car ride, or blame it on reading in the dark, or blame it on something,
Absolutely.
and not get in, right?
Yes, a lot depends upon the savvy of the physician that does the referral. If you're tuned into that sort of a situation, then you'll tend to obviously do the right sort of exam. MRIs have really changed our ability to diagnose the disease earlier. And
if the person talks with their doctor in an honest, open way and says, got these unusual, subtle symptoms, right?
Well, unfortunately, what happens is that since a lot of the people that have MS are women, some physicians had to say, well, it's just anxiety or stress, or they tend to get blown off, unfortunately. So there may be an interval there where the person will have difficulties and not really be taken seriously enough to be sent for further testing.
So it behooves the patient, potential patient, to
be their own
an advocate
Absolutely,
and
absolutely.
To holler if you
Yes,
are worried.
Yes. I mean, everyone is anxious, everyone is stressed, so that isn't sufficient to explain the difficulties.
Right, exactly. And I just learned today, really, in some reading, that it is important to be diagnosed early.
It is.
And
the
I don't
reason
know
is
that
because,
I knew that before.
Well, as I just mentioned, MS is an evolving disease. It changes over time. The underlying pathology of the disease evolves, so that someone who initially has relapsing remitting disease, once they become secondary progressive, have a different underlying state of inflammation, and actually none of our medicines work at that phase of the disease. All of the drugs we have are anti-inflammatory. As I mentioned, MS is an inflammation of the brain, patchy inflammation. So the best time to treat that inflammation is when it's at its worst. And that's at the beginning of the disease, before you have a lot of tissue destruction.
And that can affect the severity of the disease?
Absolutely.
And
Absolutely.
It can affect the cognition issues that you might have down the road?
It can, but there are multiple disease processes going on at the same time. That's one of the things I learned at that meeting when I was in Amsterdam. You were just mentioning that.
Right.
How complex it's now become. It used to be fairly straightforward. There was inflammation around the blood vessels. That was the main thing that was happening. Now we know that there are at least 5 different things going on concurrently, and that the balance between them changes over time. So that if you're going to do anything, it has to be done early.
So anyone who's watching and says, I wonder some of these things he's saying resonate, get to your doctor and
Sure.
talk about this.
Yes, absolutely.
In terms of some of the new things on the horizon, some are experimental drugs,
Yes.
but some are really quite quite here to stay too, aren't they?
Yes, yes.
Tell us what you learned in Amsterdam about new drugs and how they're competing with some of the old ones that are the standbys like Copaxone.
Sure. All of the evolving drugs, or emerging drugs, I should say, are all anti-inflammatory. So they all kind of do the same thing. They cut down brain inflammation, but in different ways. So they have different mechanisms of action. Is one mechanism better than another? We don't know that. You really have to have a head-to-head trial to allow one to say that. That has not been done. But it is being done in certain instances. So you can say that some drugs perhaps are more effective, but they're all aimed at the relapsing, remitting form of the disease. So they all address the acute inflammation you see at that phase of the illness. Unfortunately, you have an ongoing disease process in which inflammation isn't that important after 15 or 20 years. What we need are medications that address the subsequent patterns of tissue destruction.
Are researchers hearing that from the doctors who are...
Oh, they're well aware. The problem is understanding the mechanisms of what's going on.
And
There's so many different things going on that it's really hard to appreciate that. What will eventually happen, I believe, is that you'll have medicines for the beginning of the disease, medicines that are important after the disease has been around, or maybe even combination therapies from onset, so that you're addressing all facets of the disease process.
Do you hear anything about prevention in terms of what we maybe can do to prevent getting MS?
Well, there have been many theories. As I mentioned, vitamin D has been in the spotlight for the past 4 or 5 years now. There are some data to suggest that a low vitamin D level may predispose you for the development of the disease, not by itself. You have to have the genes and the environment and everything else.
And how low? I think people are starting to tune into vitamin D.
Yes.
They know that between 30 and 80 or 90 is kind of a range.
That's the range. We think that's the normal range.
What would be low for
Well, I've seen people with MS who have vitamin D levels in the teens. And otherwise perfectly healthy except for their MS. And it might not have anything to do so much with sun exposure as your genes. How you metabolize vitamin D, how you deal with it, how it enters your metabolism may be the result of your susceptibility genes. So you could be out in the sun all day and still not have a sufficient vitamin D level.
Your genes aren't working for you with the vitamin D. So the future looks exciting in terms
very exciting.
Of drug treatment.
Yes.
Are there any other kinds of therapies that are out there that you're looking at carefully in terms of treatment?
You mean alternative therapies?
Alternative, or, some people have written a little bit about surgery.
Oh, yeah. There was a big brouhaha, if you will, about 2 or 3 years ago.
In Italy, right?
Right. There was a physician there who felt that MS was a result of blockage of the veins that drain the brain. I think that, at least in my mind, that's been pretty well disproven, and I don't recommend that to anyone, even though, unfortunately, there are still people who are seeking that therapy, and you can have it done in Minnesota, but I'm not sure that that's appropriate.
Okay, so people should not be holding out hope for that.
I do not believe that is an adequate therapy for MS.
Depression goes along with MS quite often, as it does with many chronic illnesses.
It does.
The long-term draining effect. Do you recommend to your patients that they watch carefully to see if they are showing signs of depression and get treated as soon as possible if they are depressed?
Well, that's a very important question. Mood disorders are very common in MS. Having any long-term chronic illness of uncertain course has the potential to make you very, very depressed. Not just you, but other family members too.
Right, the caregiver.
And it's extremely difficult. So yes, I'm very tuned in to a person's mood. What I think is important is for people to understand that depression isn't just sitting in the corner and crying all day. It takes many different forms.
That's a very good
Overeating,
point.
undereating, poor sleep habits, inability to concentrate, short fuse, angry all the time. Those are all symptoms of depression. People don't understand that, so when I tell them, I think you're depressed, they say, oh no, I'm not depressed, I'm not sad. But they really are, but in a different way. So I have to explain to them that these are indeed symptoms of depression, and then I do treat them.
I once heard, I was at the Mayo Clinic at a workshop and heard that men often show depression via irritability.
Yes.
More than women.
Yes.
But I'm sure women also exhibit that who are depressed. So I think that's a wonderful point.
Yes, it's
to
very
make.
important to realize that the symptoms of depression are
Because
very
if
multifaceted.
it's not treated, it would impact your taking care of yourself
Your quality
in
of
terms
life.
of the disease,
Absolutely.
right?
Absolutely.
I mean, they go together.
Absolutely. Yes,
that makes
that's a very
sense.
important point.
I'm getting the signal. We want to give people a website and a phone number. So take out your pen and pencil. If you want to learn more about MS, there's a wonderful website, the msassociation.org, and it talks about support group links. It talks about research. It's an exciting website. And then there's also a phone number. If you aren't a computer person, you can dial 1-800-532-7667, extension 154, and get questions answered about MS. So that's another good resource. Also, the MS Foundation has a website. You can just go to msfoundation.org, and you tell me it's a very good one, too.
There's the MS Society, of course, website. That's also very, very important.
Okay,
Yes.
with some good links to
Yes.
clinical research
Yes.
information. Well, we have 1 minute left. If someone listening has just gotten diagnosed, what would you say to them, Dr. Birnbaum, about hearing this maybe in the last few weeks or month or so?
Well, I would say the most important thing in dealing with MS is knowledge of the disease. There's a lot of misinformation out there, a lot of claims that there's a cure or alternative therapies that perhaps really don't have any major impact, are expensive and perhaps misleading. That there's a lot of hope, that there's a plethora of different medications that are now available which can really alter the course of the disease. They're safe. They're effective, they have long-term benefits, and that understanding what can happen and what can't happen is really essential to dealing with it in a healthy manner.
So educate yourself.
Absolutely.
Ask
From
questions.
reliable sources. Find a physician who knows about the disease and who can support you through this very difficult journey.
Well, thank you so much for educating me some more and sharing your great knowledge.
It's been my pleasure. Thank you.
Information with our viewers.
Thank you.
Thank you for being with us. Talk to your doctor. Don't let symptoms just ride. We'll see you next week. Until then, have a good week.